I had a very distinct, which I know was divine inspiration to start a podcast. And I barely even knew what a podcast was. I might wake up in the morning and have to write down instructions from God on what episodes to do, what order. Every discipline in the ICU or at the bedside should know the evidence, the research, the patient perspective, and understand why we're doing what we're doing at the bedside and what that's going to mean for the patient in the long run. I remember watching some clip of some medical show and it had the doctors walking a patient and I just felt so annoyed. I, as a nurse, I walk my intubated patients even without physical therapy. What I'm doing now is trying to empower nurses to be autonomous, advocate for quality improvement, bring in evidence-based practices and big changes. I have a hard time when I see nurses being portrayed as mindless, just following the orders, doing the tasks, being robotic.
Welcome to the Nurse on Purpose podcast, where we challenge media stereotypes about nursing and spotlight the incredible and diverse roles nurses play in healthcare. I'm your host, Nello. Every week, I'll be joined by a nurse who is reshaping the narrative. From frontline care to leadership, education, innovation, and beyond. Our aim is to show the world that nursing is so much more than what we see on TV. Together, we'll explore how we can collaborate with media and other stakeholders to create authentic and inspiring portrayals of nurses. Let's begin the conversation and ignite change, one episode at a time. Hello again, and welcome to the Nurse on Purpose podcast, where we break down all things media stereotypes of nursing and also highlight the incredible work that nurses are doing every day. Today, I have a very special guest with me, Kali Dayton. Kali is a critical care nurse practitioner. She's the host of the Walking Home from the ICU and Walking You Through the ICU podcasts. She's a critical care outcomes consultant. She's dedicated to creating awake and walking ICUs by ensuring ICU sedation and mobility practices are aligned with current research. She works with ICU teams internationally to transform patient outcomes through early mobility and management of delirium in the ICU. She does so much work. Her passion is focused on making sure that ICU patients are humanized and they recover safely and effectively. And so today it is my immense pleasure to welcome Kali Dayton onto the podcast. You're so welcome, Kali.
Thank you so much for having me.
So today I just wanted to really focus on the work that you're doing. And I know when I encountered you, the awake and walking ICU models was something I'd never heard of before. And I'm not currently bedside, right? But, it struck me as being very, very important work. Like, this is something that a lot of, I think, patient families struggle with, especially when their families are in the ICU, seeing them become delirious, seeing them struggle, seeing them just kind of dehumanized, laying there sedated all the time. What was it that really drove you into pursuing this initiative?
I started my career in critical care medicine in 2012, and the first ICU I worked in was what I now call an awake and walking ICU, meaning that every patient possible was awake. So even if they were on a ventilator with a breathing tube, they were not sedated. They were allowed to wake up after the procedure of placing the breathing tube and able to communicate, writing on a clipboard, texting to us, and we would get them moving, usually walking, within 12 hours after intubation. And so that was really normal. And I didn't know anything else, and so I just did what everyone else was doing, didn't think much of it. I loved working there. I had such deep connections with my patients, saw incredible successes. I didn't realize what I was doing there was novel or unique. And after a few years, I became a travel nurse. And even my very first shift in a new ICU, I had a patient assignment in which one of the patients was intubated with a breathing tube on a ventilator, and they were sedated. They were in a medically induced coma. They weren't responsive to me, and I couldn't do a full neuro exam. I couldn't get them in a chair. I didn't know how they were going to work with physical therapy. I had so many questions. So I asked the orienting nurse, hey, can I get him up and take sedation off? And they looked at me like I had 3 heads on my shoulders, right? And I said, are you serious? No, they're intubated. To which I said, I know they're intubated, but why are they sedated? And we went in circles on this. And that was the first time I had realized that this was the common mentality throughout the rest of the critical care community, that every patient connected to a ventilator was going to be sedated, unresponsive, and immobilized, and weren't going to move until they got off the ventilator. And back then, I didn't know the harm of that. And everyone was doing it. It was just so normalized that I thought, well, it must be okay. I mean, maybe there's something I don't know. And they certainly are not open to me sharing what I was used to, because I would explain, well, I'm used to my patients being awake and like taking them on walks and stuff. And they just could not believe that. So instead of trying to convince them, I just went with what was normal, not knowing how much harm I was causing, because no one had taught me why we did things that way. It was just, you just do it. And sometimes that's the way medicine goes, is we're just doing tasks without knowing the why. So I really wasn't empowered to advocate for my patients or explain my practices because I didn't know the why. So I did the normal thing, sedated many patients for about 2 years as a travel nurse throughout many ICUs. And I almost left nursing. I was so burnt out. I had very little career fulfillment, but I did decide to go back to grad school. And I went back to the first city that I had started my career in Salt Lake City, Utah, and returned to the Awake and Walking ICU. And I almost had another level of shock to realize, no way, I'm not crazy. I didn't make it up. These patients really are so sick. Multi-organ failure, septic shock, ARDS, and they're awake, sitting at the side of the bed, sitting in a chair, a lot of times walking. They're not sedated automatically, and they do so well. And they're getting off the ventilators. If we don't do tracheostomies here, I just had so many questions. And started to look into the research. So this is about 2016. And the more I learned, the more I realized there's no way that my colleagues and all these other ICUs knew what I'm reading here. I don't think they knew the harm of what we were doing to these patients. It was just so normal. They don't know that what we're doing here in this first ICU, and what I now call an awake and walking ICU, they don't know that this is possible, let alone how beneficial it is. So I just felt this weight of responsibility to disseminate this information, but I had no idea how to, because I had already tried to talk about this to other people and was very dismissed. And so I knew this wasn't going to be very easy or well received. And December of 2019, I had a very distinct, which I know was divine inspiration, to start a podcast. And I barely even knew what a podcast was. I didn't listen to podcasts. So I was
you're speaking my language, girl.
I know. Having this chat with God where I'm like, a what?
I'm like, what mic do I like? I don't know what you're talking about.
I don't know anything. I'm like, is that like reading the book, right? Like, I just had no idea other than that I was going to do it.
Got you.
And it just felt right. So I got that inspiration late 2019, December. I might wake up in the morning and have to write down instructions from God on what episodes to do, what order to do them in. People came out of the woodwork, survivors, ICU survivors, my colleagues, other clinicians, and it just fell together. And I had this, like, part of the instruction was I had to do, like, it was like 32 episodes by the beginning of March, by March 5th.
Wow.
And I was like, that's so much. I don't know podcasts, but I'm pretty sure you don't just do a big episode dump.
Right.
But I couldn't shake it. And so I thought, okay, I'm going to do that, and then I'll be done. This little passion project is going to be done.
Wow.
I'm like, God's going to let me sleep when I do this.
Nope.
Yeah, so I did that, not knowing that, boom, COVID was coming.
Oh, my goodness.
And I thought, because this is now March of 2020 when I did this big dump. And I thought, well, now no one's going to care about this because now it's all about COVID. And God shook me by the shoulders and said, are you serious? After all you studied and now put out all this content and you don't get it.
Oh,
Millions
wow.
of people will be on ventilators. This is a huge preparation for COVID. And so it didn't really change COVID for a lot of people. But I think people could hear it and they could see it so clearly. The problems, the delirium, the death, the tracheostomies, the deconditioning, all these things that I was talking about in the podcast was so blatantly before them
Yes.
during COVID. It was just a really hard time to make this kind of radical transformation, right? But I kept the podcast going. To me, it felt like investigative journalism. I just couldn't
Yeah.
stop because I wanted to
Yeah.
figure it out. There's so
Yeah.
much science behind it. And again, I just thought this was a passion project. But I started to do ground rounds for teams. Podcast listeners would reach out and say, hey, can you talk to our team about this? So I would do this presentation where I'd share case studies, pictures, and videos of my patients, some of them my COVID patients.
Wow.
And I was just dropping this big truth bomb, this big weighted, hey, you're hurting people, and here's what we're doing, so just do it this way. I was pretty naive to not really understanding how hard this change was because in my ICU, they had
Yeah.
done this for almost 25 years. It was a well-run machine. But in other ICUs, this is a whole new perspective, skill set, so many barriers that stop them from being able to do this. So I quickly learned that teams need not just the weight of, oh my gosh, we're hurting people. They don't need more moral injury. They need support. They
Right.
need the education, the tools, the training to be able to change these practices. And I realized that no one else was going to provide that. So I started Dayton ICU Consulting to try to have the chance to go in and train these teams. And at this point, I've now trained 13 with really exciting success. It drastically decreases healthcare costs. Teams have saved millions of dollars within the first
Wow.
year after training.
Wow.
Drastically saves lives, quality of life, the team
That's
morale. This has been a journey of healing from these ICU teams post-COVID to learn how to work together, to carry the burden of care together, to have the fulfillment of seeing patients do well,
wow.
having human connection with them, having them successfully get off the ventilator and walk out the doors. And so it just changes so much for these patients. I've continued the podcast. I now have 187 episodes right now, and much more content to put out. There's just so much that I've needed to learn and share through this journey.
That is amazing. Your story is so powerful. I have all kinds of questions because you were dropping everything. So in the beginning, you said there was something you didn't know. Maybe, you just decided, you know what, maybe there's something I don't know about the research. I'm just going to go with it. So was there something you didn't know that other people knew?
I think very few people knew. When I was, so back in 2012, my first ICU had put out a study in 2007 showing that it was safe and feasible to walk patients on ventilators. And that had really set off a lot more early mobility studies. And so there was a study that came out in 2009, a really great one, another one in 2011 from Johns Hopkins, but they were just very small, isolated units doing this.
Got it.
Some of them only doing it for the study, and then it kind of things would go back to normal.
Yeah, right.
So it was not common knowledge or standardized that patients should be awake and moving. In the early 2000s, we'd started to do a lot of research on what happens to these patients in and after the ICU when we sedate them and leave them in bed. But that knowledge, that research had not really infiltrated most ICUs and reached the bedside.
Yeah.
So I was never made aware of that research. I'd never talked to a survivor. I'd never heard them say, I was not sleeping. I thought my deceased father was cannibalizing me.
Wow.
Had I known that we send people into far worse places in the ICU, I wouldn't have laughed about sedating them. I wouldn't have sedated them because I knew how to keep them awake and mobile.
Right.
I just didn't know why.
Right.
So when the culture that surrounded me was a certain way, I succumbed to the culture.
Gotcha. Understood.
Otherwise, I would have advocated.
Yes.
But I didn't have the tools.
You didn't
So
have
that really propelled me to put out a lot of education because I think, especially nurses, but every discipline in the ICU or at the bedside should know the evidence, the research, the patient perspective, and understand why we're doing what we're doing at the bedside and what
Yeah,
that's going to mean for the patient in the long run.
absolutely.
And all this information that I wish I'd known, I now make sure is in the hands of clinicians.
Absolutely. I love that. One thing that you mentioned was evidence based practices. A lot of times when we step into practice as nurses, the sheer volume of work keeps us completely busy and drained and depleted that we don't really even have time to be the scientists that we are. We just, okay, we have such and such number of patients in the ICU. I'm sure you have less patients, but a lot more complexity, so you're constantly busy. You're constantly, filling out checklists to do this and do that. So I feel like we need to go back to that structure where we rethink what is the path though? What's the why? What's the mechanism of action of the drug? Like we really do need to go back to thinking like scientists again. Otherwise, people will tell us something and we'll just say, well, they have the degree, so they must know, and we'll believe it and go with it. Meanwhile, God is calling us to a greater and a higher calling. And so that was really powerful what you said. And then you mentioned divine, it was like a divine tap on your shoulder and you couldn't shake it. Yes, I know that feeling because when I wanted to start, well, I didn't even want to start it really. When I felt the nudge to start the podcast, I was like, podcast who? What are you talking about? I'm still trying to deal with like YouTube and putting my face out there because that is just so far out of my comfort zone. And now you're
Mm-hmm.
telling me to start a podcast. But like you said, I couldn't get any sleep. It was like, do it and do it now.
Yeah.
And so the next day, I was like, all right, I guess I need a mic. What do people do? Like,
Yeah.
Googling, well, how do you start a podcast and buying a mic? And I'm like, okay, I guess I need a laptop. I didn't even have a laptop. Like I had my Mac, but it was like memory full. It's a personal laptop. And I had to buy a laptop. And then I was like, I guess people use a camera. And then I had to buy it. I mean, just like day by day, figuring it out. And then I'm like, so now what next? So then I reached out to a few podcasters to ask them, what is your, what's your step by step? And very lovely people, very nice enough to kind of tell me, okay, this is what I do. You can modify it. And that's how this all started, really. In December, I had the thought in maybe November, and I started recording in December. So here we are. Yeah, that divine tap feels more like a punch. But it stays with you until you respond. And then when you do, you really start to see the why and the doors start to open up. So, I mean, I admire you for stepping out and now seeing the impact that you're able to make in people's lives. That's incredible.
I thought it was going to be career suicide. I just thought I knew I was going to be exposing some really ugly sides of medicine, some
Mm-hmm.
hard truths.
Yeah,
And I also knew I couldn't work in any other ICU until this problem was fixed. Like
yeah,
ethically, I
yeah,
couldn't just be a chameleon anymore.
yeah.
I couldn't just go with the norm anymore. And I just assumed, one, I thought I was going to get fired from my current job because it was a
Mm-hmm.
multi-hospital system where that
Mm-hmm.
ICU was located.
Yeah.
And it was the only ICU doing what it was doing. So by talking about that ICU, it was going to kind of expose the other ICUs.
Wow.
And so that's why I called it an awake and walking ICU, because I didn't want to have legal problems.
Yeah.
So now it's fun. I mean, that really, I think, was a divine inspiration too, to call it an awake and walking ICU.
Mm-hmm.
My motive was to have a smoke screen to be able to talk about the ICU without saying what ICU it was.
Right. What it was. Mm-hmm.
But now I realize it's not about one ICU. It's about a process of care that gives
Right.
patients the best chance to survive and thrive.
Absolutely.
And now, even if I'm not at conferences, people will text me and
Mhm.
saying, hey, they're talking about awake and walking ICUs, which is such a dream come true. I had no idea where this is headed. I
Mhm.
don't think I would have signed up for it because it's been so hard, but I feel like I got hoodwinked a little bit by God, but
Mhm.
it's been incredibly fulfilling. And I feel like I have transformed as a nurse. I look back to
Mhm.
what I was doing in 2012 in the Wake and Walking ICU. I was just robotic, doing what everyone else is doing what
Yeah.
I was told, following orders,
Yeah.
just doing
Yeah.
normal process. Then I went to Other ICUs in 2014, same thing, doing whatever else doing the tasks list, doing what was ordered, which is part of the nursing responsibility, but we're more than that.
Yes, absolutely.
And that's what I see that really irks me in the media.
Yeah.
And to see other nurses believe that we just follow orders.
Orders, yeah.
Which we do, but we are charged with the responsibility of being up to date on the evidence, critically thinking and advocating for our patients.
Absolutely.
And so that's what really guides me when I train teams, and especially the nurses, to say, you need to be thinking through this to say, is this worth the risk? Do they have to have sedation? Why can't we mobilize them? And it's amazing to see when nurses really get it. They are guard dogs.
Oh,
I mean, if a physician writes sedation orders that are not needed,
they're going for
and I've seen this when a new physician comes in or they're visiting from another place and they write these orders, the nurses are saying, no, that's not safe.
Yeah.
That patient doesn't need sedation. Yeah. And the physicians are so confused. And then, they talk about it, they escalate to their leadership. Yeah. So it takes a whole system that needs to empower the nurse to be able to be that advocate.
And speak up.
But when they know the why and they're confident in the how,
yes,
they're going to do what's best for their patient. And that's what I want to see portrayed in the media, is that nurses are the guard dogs.
Absolutely.
And that they know the evidence and they advocate for it and they are autonomous.
Yeah. Yeah. So the light bulb went off for you and you're like, I'm going to light up this entire profession.
I'm going to burn this old antiquated care to the ground.
Yes.
We've got to start over and really figure out what is best for patients.
Yeah.
And I believe that it needs to be nursing led.
Yeah. That's what it's about. Because we're the 24-hour, hands, feet, eyes, everything on ground. And in a way, I don't really, you don't fault the physicians because they're also following what they've been told. This is what they were taught in school, in residency and fellowship. So they're following just what they know. So it does take another, enlightened group to say, let's stop this for a second. And let's think through how, we're hurting our patients, what we can do better. And there should be no power struggle involved. There's no pride. It's just about let's do what's best for the patient, which, that's the best part of this entire thing, is that families can see their patients. Families that are in the hospital, they can see them thrive and not look so, defeated, comatose. I had a family member in the hospital and he went from the ICU. While he was there, he was heavily sedated. He became delirious. He became combative. I mean, he was just hallucinating, and they would keep on giving him these meds. And he was always in a state of sleepiness. I mean, this would have saved his life. It would have improved his quality of life so greatly. So, girl, you're doing God's work.
Well, we had a huge study come out in 2019 looking at this kind of process of care throughout 68 facilities and over 15,000 patients. So it was a big study.
Yeah.
And they weren't fully awake and walking yet, many of those patients.
Yeah.
But by drastically decreasing sedation, keeping patients more awake, turning it off sooner, avoiding the most dangerous benzodiazepine sedatives, they decreased 7-day mortality by 68%.
68%.
Yeah. And yet COVID came and we kind of ran back to what we were doing in the 90s and really regressed. And so it's bringing that research to the bedside to say, we can do that and better.
Yeah.
But the nurses, there's so many logistics behind it. It's not about just not giving sedation. It's what you do instead.
Yeah.
And that's where I find that physicians can read the research and be like, wow, the data there is compelling. The statistics are very convincing. This is the right thing to do, but do they know how to do it?
How to do it.
And a lot of these are nursing skills, these holistic approaches that are part of our values, our intuition. Sometimes are scoffed at in the ICU because it's all about the big, sexy procedures. But things like holding a patient's hand, connecting them with their loved ones, playing the music, talking to them, making eye contact and saying, hey, you're in the ICU. That's a breathing tube keeping you alive. Don't touch it. Those things seem little compared to putting in the lines and drains and all these things, but those things save lives. You can keep a patient oriented, connected to reality, understanding their environment so they don't dislodge their lines and tubes.
Absolutely.
Therefore, you don't have to sedate them.
Yeah.
Therefore, you can get them mobile. You have
Yeah.
drastically changed their chance to survive and thrive, because what we do not only increases mortality in the ICU
Mhm.
through sedation and immobility, but it changes their lives forever. They end up with brain injuries,
Yeah.
PTSD from that delirium, and physical impairments. They lose massive muscle mass
Yeah.
and function, and that can change their lives forever.
Forever.
So, as nurses, when they figure out the why, they figure out the how, and all the nursing logistics behind it, they become powerful leaders in the ICU, and they change the course of innumerable lives forever.
That is powerful. You're treating the whole person, and that's what I hear. It's
Yep.
not, like you said, the grand, inserting lines. It's all of the person. It's the emotional part of the person. It's their soul, it's their spirit, and it's their body, right? Have you encountered a lot of pushback or just, setbacks? I know you said it's challenging. It's been a hard, journey so far. What have been some of the biggest challenges that you faced in your journey?
It defies everything that clinicians in the ICU, and especially nurses, have ever been exposed to, ever done, or ever believed. So for me to come out and say, hey, let's avoid sedation, most patients don't even need it, let's keep it off,
Yeah.
really enrages people initially. There's like a visceral response.
Yeah.
Because when you start sedation, you keep it running for days to weeks, then when you turn it off to try to get someone off the ventilator, they are usually, like you've described, delirious. They're confused. They think they've been kidnapped. They think they've been sexually
Hmm.
assaulted.
Hmm.
They think they have a snake down their throat.
Yeah.
So they come out combative.
Yeah.
They come out agitated. They're trying to pull out their lines and their tubes. And it's very stressful for the nurses and for the physicians and for the respiratory therapists. Everyone involved hates that scenario. And they associate that with taking off sedation. So when I say we're not going to sedate people as a norm, not that we never
Hmm.
use sedation, but we're going to let most patients wake up, they imagine naturally that
Hmm.
everyone's going to be thrashing.
Right.
And when they have only experienced mobilizing patients as taking these large flaccid bodies to the side of the bed, and it takes 5 people to hold
Mm.
them up for them
Hmm.
because they don't have any strength to move their own
Hmm.
bodies, they say, we do not have the workforce. We do not have the
It's,
staffing for that.
yeah.
So they're imagining something entirely different. What I'm talking about is letting patients wake up promptly while they still have their coping mechanisms intact. They're oriented. They can
Got it.
communicate their needs. We can meet their
Good.
needs. They can move their own bodies. All of this is so much easier, but it's a lot to explain. So when I
Yeah.
initially say, and they see these posts, they're like, that's not possible. That's not,
Hmm.
most of my patients can't do that. And they get very defensive. So there's a
Hmm.
lot of, like you said, pride. It's
Yeah.
very natural. It's hard to accept that we've hurt people. That
Hmm.
takes a lot of humility. And I'm the first to admit it.
Yeah.
I think I'm the most guilty. I came from a process of care where I was doing all the right things, but I didn't know why. And so when I went to the other cultural norm, I knew better. In a lot of
Yeah.
ways, I knew better.
Yeah.
And so I'm willing to admit that, but that's
Hmm.
hard. That's because I've spent years working on that, admitting that I hurt patients. But there's a natural response to
Yeah.
that. That is a big challenge for me to figure out how to navigate being bold, saying we are hurting people, but
Yeah.
also not causing people to be defensive.
Yeah.
So when I train teams, there's a whole spectrum of response, but oftentimes people are very skeptical, very defensive, very on guard. They think that I'm just
Hmm.
corporate, that I have no clinical experience, that I'm just blowing smoke. This isn't really possible. This won't happen in
Right.
their ICU. And I embrace it all. Like, let's work through it. Let's talk
Yeah.
about it.
Yeah.
Let's put it on the table and hash through
Yeah.
it. I know when I show up finally in person, my face is on a dartboard.
Yeah.
They're they've been, they've been cursing my name, but by the
Target.
end, when they see this work for their patients, it's
Hmm.
all good. We're all friends, and
Love it.
they run with it.
I love it. You have to have thick skin to do the kind of work that you're doing because people are not really, they're averse to change. They want to stay where they are. It's like when they introduced Epic or whatever EMR and everyone went crazy. Wow. And it's like, it's going to help your life. It makes your life easier. Why would you oppose this? But people like their comfort zone by default. So understood. When you go to a hospital to implement this model, what do you typically like? Tell me the process. How do you connect with them? And then how do you go about providing them those resources that they are needing to be able to easily implement this or even accept this change?
How I connect with them is variable. It could be because someone saw me at a conference, or oftentimes podcast listeners. So sometimes it's bedside clinicians hearing this, being moved by it, being haunted by it, unfortunately, and saying, well, I've got to change this. Can you come help? Then we go through this whole process of, let's get your data together. Let's show your executive leadership team where you're losing money in this, the financial and legal liabilities of this, so that they're willing to support these kind of changes, because teams need support, not just my services, but equipment, sometimes staffing. I've been able to get extra nurses or extra mobility techs through using the evidence, the financial benefits that we know this brings. So we have to go through that whole process of getting clinical leadership buy-in. Then once my services are secured, then I start to meet with leadership of each discipline. So rehab, respiratory, medical, nursing, and talking about what their role is going to be, how they need to lead their own discipline to play nicely and well and collaborate as a team. Then we do webinars, and I customize them for their team's needs, their patient population, and we talk in depth about the why, about delirium, about ICU acquired weakness, about what is an awake and walking ICU, what are the steps to get there. And then I come on site with a team, because it takes a team. So I bring a respiratory therapist with me and a physical or occupational therapist, because the team needs to see me work with a team. And our Ts don't want to hear it from an NP with a lot of RN experience. Like, they want to hear it from their own discipline. So I make sure that happens.
Absolutely.
When we come on site and we participate in rounds, we weigh in on their plan of care for their current patients. We'll stand at the doorway and help coach them through implementing these principles to their own patients. And we also do simulation training, which is so important, where they get to have 2 hours to collaborate, talk through, practice with their colleagues. Physicians are standing next to an RT, next to a CNA, next to an OT, next to an NP. So we can really work through what's everyone's roles. How are we going to do this? They practice critical thinking with, quote, real patients. Someone's in the bed pretending to be the patient. But then the case study is from their own ICU. So we also are doing a gap analysis. We figure out what else do they need? What do they need to work on? What are the next goals for the next month? And then I meet back with them virtually next month and the next month, and for 6 to 12 months after, to make sure that they're meeting their goals and they're progressing.
That is amazing. So it sounds like it's a full day of kind of training, onboarding, that kind of stuff.
And night. So we train day and night shift. So it's a little exhausting for my team and myself, but totally worth it. So we'll be there from like 8 a.m. We take a little break around 5. We come back at 9. And are there until 11:30.
And then the nurses who don't have the opportunity to be at the training physically, maybe they weren't working that day, do you have appoint people who will then train them?
We stay there for 3 or 4 days.
Oh, okay. So you're there over a couple of days. Okay.
Yep. Oh, yeah. Because the goal is to train every single member of the team.
Yes. Okay. Got it.
Because it takes the entire team. And previous initiatives back in the 2010s, when they tried to implement these kind of changes, they would select a few champions and give them the training. But it's so imperative that every member of the team have the tools and the knowledge. So we camp out. We just hang out there for a few days and make it happen.
I want to hear if you've had any, well, I know you've had many success stories, but can you share like success stories of patients that thrived, because of this model?
Yeah, I can give an example of, I was visiting a team. I wasn't there to do the training yet. I was doing a gap analysis. So the team didn't really know me. Just a few people that wanted these changes knew me, but the rest of the team didn't know me from Adam. So I was just walking around, and I struggle with doing that, with doing a gap analysis, just walking around with the clipboard and taking notes. I can't just see the harm and not say something. So I saw a patient that was intubated on the ventilator, laying there, eyes closed, flaccid, and had a propofol drip running. So of course I had to stick my nose in, and I was like, hey, tell me about this patient. Why is he here? Why is he intubated? And why is he sedated? And they said that he had overdosed on fentanyl and Xanax. They found him with an altered level of consciousness in his hotel room, and that he had vomited and aspirated. So his lungs were full of vomit. And they had brought him to the ICU. He was on high flow nasal cannula, meaning like just really high levels of oxygen. But then his lungs started to get worse overnight, so they intubated him.
Yeah.
And I said, okay, that makes sense. And why is he sedated? And they looked at me like I was insane.
Mm-hmm.
Right? Well, of course, because he's intubated, but they said he was agitated overnight.
Mm-hmm.
And I'm looking at him, and he is about 350 pounds.
Mm.
And I said, well, if he's taking opioids and benzos and you only have propofol running, could it be like, let's think through why was he agitated?
Mm-hmm.
Why was he behaving that way? And they're like, well, because he has a breathing tube. I said, yes, that's uncomfortable, but I've seen hundreds, beyond thousands of people be okay on the breathing tube. So let's think further. Is he withdrawing?
Yeah.
We're not giving him opioids.
Right.
So I found the attending, bless his heart. It was his first week in that ICU. I think he was just off fellowship. And I am a nobody. I'm like, hey, I'm here visiting as a consultant, and I've got some thoughts and ideas. And he thinks I'm insane. And this patient had sick lungs. They were full of vomit, high ventilator settings, high levels of oxygen, high pressures. So I said, how about we try giving him some opioids and some benzos down his feeding tube so that he's not withdrawing, and then let's take sedation off and try to get him up. And they looked at me like I had 3 heads on my shoulder, right? They were just so confused. And I said, that's insane. I said, I know, but I'm here to kind of guide these things, and let's give it a try. What's the worst that could happen? And so they gave him those meds down his feeding tube, waited a while for that to absorb, and then took sedation off, and nothing happened because he had so much sedation given within those 8 hours that he just took about 6 hours for that to metabolize out. Once he came off that sedation, he was grumpy. He was banging his hands on the side rail, and instead of resuming sedation, they talked him through it. A few hours later, once that was overnight, the day shift came in, physical therapy and occupational therapy came in, and this was the first time they were getting an intubated patient up, and they were so nervous. And I said, we've got this. We can do this. And he had only been intubated for about 24 hours at that point. So he actually sat himself up, swung his own legs over the side of the bed, sat up, and you could see the anxiety just dissipate from his body. And his oxygen levels went up. He could breathe better. He could saturate better.
Yeah.
And I could see everyone else in the room was like, oh, hey. And then he pointed to the chair. He wanted to get to the chair. And they're like, can we do that? I'm like, yeah, absolutely. Like, he's still strong. He has a lot of muscle. You want him to do that before he loses his muscle.
Yeah.
So he stood himself up, walked over to the chair, sat down. And they had all these people in the room ready to catch him, but he was fine because it was so early. And they realized he could sit there with a clipboard and he could write and he could tell us his needs. He didn't need sedation. He breathed better. His ventilator settings went down. And so I left there that Friday. They kept him walking to the chair. He wanted to sit in the chair most of the time, sleep in the bed at night, back and forth. By Monday, he was off the ventilator, walking laps around the unit. Now, that was a sliding door, a glass door moment where he had 2 paths he could have gone down. Had he remained there sedated, he would have massively atrophied in his muscle mass. And with a 350-pound body, it would have come down to the clinicians to now turn that body, move that body. It would have been really hard to rehabilitate him. He would have lost the key respiratory muscles that he needs to push against his large abdomen to breathe.
Yeah.
He easily would have ended up with a tracheostomy, had to go into his nursing home or LTAC to rehabilitate.
Infections upon infections.
He already had polysubstance abuse, probably had psychiatric problems. So more trauma, more physical impairments, more disability. He was only 36.
Yeah.
I just suspected that would have shot his chances of rehabilitating from his polysubstance abuse. It would have changed his life forever. It would have given him a brain injury, which would have made it harder to live a normal life after that. Absolutely. So they changed everything, especially their workload, their risks, because if he'd gotten delirious, he was big, he was strong, he could have hurt someone.
Yeah.
But they kept everyone safer by keeping him awake and mobile. So it was amazing for them to see someone so complicated, so it's such sick lungs, polysubstance abuse, bariatric patient, be awake. He could have been walking, but the team wasn't ready for that. But he was taking his own steps to the chair. And that really propelled the team into where they're at now, which is if you walk onto the unit in that ICU, everyone is awake, sitting in a chair, unless there's a good reason for them not to be. And it's changed everything, their length of stay, their survival, their tracheostomy rates, the infection rates. They don't get ventilator-associated pneumonias anymore. They don't get pressure injuries anymore. It just changes everything, but especially the environment. The team is so proud
Yeah.
of what they've accomplished. They have such fulfillment in their careers because they're giving patients the best chance to survive and thrive. So that's just a little taste of the
Yeah.
kind of glory, like
That is
the joy that I get to
amazing.
experience in what I'm doing.
Yeah. And that gives you so much fulfillment as a nurse, seeing patients getting better. Every day you come on shift, you're like, oh, now, we always feel so gratified when we see that the patient was doing this and now he's doing this, and we all kind of celebrated together. So that's a big win. Very proud of you. Very, I admire you greatly for all of this, this great work that you're doing. I know that there will be certain patients who are not quite ready to get up yet. And you've kind of alluded to that if there's nothing stopping you, then you should be up, meaning that there are people who may not be quite there yet, but it's still your goal to get them there. What are some factors that you consider or some safety considerations when it comes to getting patients that are intubated to be more mobile? And is there something that you would say, okay, if this patient is this XYZ, that's not a candidate right now?
They have to be physiologically stable. So meaning they have to be perfusing, oxygenated, and able to move. So if someone can barely hold their own head up, or they can't hold themselves up at the side of the bed, they're not going to be walking yet.
Right.
Right. So we're just doing whatever level of mobility they can do if they can do it. So if a patient cannot oxygenate with movement, which can happen with severe cardiogenic shock or severe ARDS, that's a stop. That's a hold. If they're in such severe septic shock or even cardiogenic shock and their blood pressure plummets when they get up, that's a hold. But we might even try other things. Like now we have verticalization beds where the bed can stand them up. So they're not having to
Put the
consume
effort
oxygen using their own muscles, but they can get into a better position where they are bearing weight in their lower extremity. So even if they have intracranial hypertension, where they have a lot of pressures in their brain, and you might have to sedate them to keep the pressures down, you can stand them up. That decreases the pressure in the brain. You might be able to turn sedation down, but you're at least bearing weight in your extremities and preserving those key muscles. Absolutely. So there are more approaches and tools that we can start using, even for those exceptions. But those are exceptions. Right now, the standard in most ICUs is sometimes even intubated or not, you're not getting out of bed. But especially if you're intubated, you're not getting out of bed, you're not moving, you're not even awake. So we're taking that standard and flipping it to say everyone's awake and moving to their best of their ability, unless there are exceptions.
Kali, what are some of your goals in the coming years? What would you like to see? What's your vision for Awake and Walking?
I obviously want it to be the standard.
Yeah.
So every ICU should be an Awake and Walking ICU.
Yes.
That's a long goal because it's such a big change. Even for this next year, I'd like to be growing my team. I'd like to take people that I've trained. Now, some of these experts that have spent about 2 years or more practicing this way, I'd like to borrow them to go train other teams. Absolutely. It's really, and I've done that a few times now with a few clinicians. It's really powerful for them to say, hey, in 2021, I felt this exact same way. We were right where you're at, but here's where we're at now, and here's what's helped us. So I look forward to using more expertise that's been developed over the years, reaching more teams, and just having this become not such a shocking concept. I think we're still in a shock phase where it sounds crazy, maybe it's possible, to, well, of course.
Yes.
I'd like to see that shift happen.
Yes, absolutely. Medicine evolves. This is a great evolution. And of course, with your consistency and given this time, it's a worthy goal to kind of pursue after. So I look forward to also seeing the Kali effect all across the nation. That's what I'll be calling it, the Kali effect. I know they'll call it the Awake and Walking ICU model, but I'll have my own special name for it. So I look forward to that. We're going to transition now because I want to talk about media portrayals, which I think you kind of touched on a little bit, but I want to focus just for a few more minutes before we wrap our time together. If you watch any shows, right? Some people do, some don't, but even if you don't, you're aware. What is your opinion about the media portrayals of nursing?
remember watching some clip of some medical show, and it had the doctors walking a patient that wasn't even intubated, right? They were just doing the, and I just felt so annoyed. I was like, I, as a nurse, I
Yeah.
walk my intubated patients even without physical therapy at
Yeah.
night with
Yeah.
respiratory therapy and a
Right.
family member pushing the wheelchair.
Right.
Like that's what I mean. I do that care. And I just see, especially since what I'm doing now is trying to empower nurses to be autonomous, advocate for quality improvement, bring in evidence-based
Yeah.
practices and big changes.
Yeah.
I have a hard time when I see nurses being portrayed as mindless, just following the orders, doing the tasks, being robotic, partially because I've been there,
Mm-hmm.
because I've been that nurse
Mm-hmm.
early on. But when you're young, that's all you can do at that time, right?
Mm-hmm.
But that's not what nurses truly are or are supposed to become. And so I get bugged because I've met so many nurses now that are what I call revolutionists, people that are advocating for these changes, this huge transformation away from walk-in
Huge.
ICUs
Yeah.
are revolutionists.
Yes.
And I've met so many nurses that are going beyond, far beyond. I mean, they're trying to educate the highest up on these
Yes.
changes,
Yeah.
and they're not just following orders mindlessly. They
Yeah.
are challenging those orders. They are challenging the entire system. And so that's what I want nurses to be seen as instigators of changes that save lives.
That was, I think, the driver for my passion as well, is that the things that I was seeing on screen were just not kind of correlating with what I was exposed to in real life. The two realms were not, it wasn't making sense to me, right? It wasn't matching up. And I was like, that's frustrating because you go to work and you work your butt off and you do all of this life-saving care, and then you come home and then you turn on your TV, and what do you see? Some like, oh, I'll go get the doctor for you, or and I'm just like, I'm just going to turn this off because that's not what I did for the last 12 hours. Okay, so I can see how that would be so frustrating for a lot of us, but sometimes we just don't have the strength. Like, we know something is wrong with the system, but we're so busy. We have families, we have, our 12-hour shifts can be tiring. And then we don't have the extra muscle to go and like advocate and do all of this stuff. And so that's what led me to be the voice and just wanting to get other voices heard. Say, hey, this is Kali. She has done this awesome work as an ICU consultant, and she's a nurse. Like, I want to highlight real life nurses and kind of show the world who a nurse is beyond the on-screen image.
I even see that the most serious conversations, obviously, physicians are involved in those
Yes.
serious conversations. But what we don't see in the media is the follow-up conversations with the nurses,
Yeah.
helping work through the feelings, the turmoil, clarifying those questions after those big diagnoses or big conversations with the physicians, the nurses following up and saying, what questions do you have?
Yeah.
Let's make sure you actually
Yeah.
understand.
Absolutely.
And even I have been a PICU mom. My daughter was in the ICU. She has mitochondrial disease, so a severe disability and medical condition. And this is before we had a diagnosis for her, and she was in the ICU. And I know ICU, right? I worked
Yeah.
ICU most of my career, and I was a nurse practitioner at that point, but yet I was still so overwhelmed. And just throughout our journey throughout the hospital, I had these nurses that I had two different nurses that had children with mitochondrial disease. So even though we didn't have that diagnosis, I felt like they were sent to us, and they were preparing me for a feeding tube for her,
Wow.
for a wheelchair. I mean, she was 17 months at the time, so we weren't
Yeah.
there yet. And I psychologically wasn't there yet. And they intuitively knew to share their own experiences and to talk to me and prepare me for those things. The
Mm.
physicians didn't bring those things up. It was the nurses saying, yeah, well, my daughter has a feeding tube and we really appreciate it. We really love it. And I look back and I'm like, those nurses, they knew, they had intuition. They knew where we were headed before I was ready to accept it. But I was so much more ready because of those conversations that I had at those key times. And it was the nurses. But you don't see that happening.
Never.
You see these intimate connections with physicians, which in reality, they don't have time to have those moments. It's the nurses
Yeah.
that are guiding the patients and the families throughout this really crazy journey. It's the
Yeah.
nurses.
Yeah. That's what we want to see. We want to see more of our work be seen, be valued, and be represented. I love that. You mentioned such a personal story and something that happened when your daughter was 17 months. I don't know how old she is now. You
Five
can,
and a half and
you can,
thriving.
5 years ago, and you can still remember that. That's the kind of impact that nurses have on their patients. We're going to talk about something kind of fun and exciting. It's a game that I play with all my guests, and I hope you're ready to be a screenwriter um, because I'm going to turn you into one in just a second. So, we know what we don't like. I want to talk about what we do want to see, but maybe just make it up in your own fun Kali way. Okay. So I have a jar with me that I'm going to shake around. It contains several categories of film, different genres, could be comedy, drama, what have you. So when I shake it, I'm going to pull one out of the container and I'll read it to you. And once I do that, you're going to become a screenwriter and tell me the plot line of your own show. If you were to come up with a show, if you were to write a book, a children's book, whatever the case is, just give me sort of your own plot line for that. You ready?
Yep.
Let's do this. Okay. Shake, 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 shake. Your category is, are you ready?
Mm-hmm.
History of nursing.
That's actually a perfect one because
Is it?
it is because listen, I didn't come up with this process of
Yeah.
care. I was, what I say, born into it. And if I were to write a movie with the history of nursing, I would talk about my mentor, Polly Bailey. She was a nurse in the 1990s when we were giving morphine, Ativan drips, paralytics, high doses for weeks. And she was just doing whatever else was doing. We didn't have research showing us how lethal that was and how harmful it was. But she followed a patient out of the ICU that was from her own community, her neighborhood. And she would go visit her in her home. And she saw this woman in her early 30s with 3 little kids be completely physically, cognitively, and psychologically destroyed after having been in a medically induced coma. And she went back to her medical director and she said, "What are we doing all this work for if that's the life we send them off to?" And he said, "Well, what's causing that? What is that? Like, what would you diagnose that as? What does the research show?" So she went to the research, but there was none. And so she went back to Dr. Klimmer. He's in episode 2 of my podcast. And she said, there's nothing in the research, but I really think it's the sedatives we're giving and leaving them in bed. And he said, "Okay, well, what else can we do? What do we know about that?
Yeah.
What are our options? Go to the
Wow.
research." So she
Yeah.
looked at the research. There was none. So she came back and said, "There's nothing, but just let me try. What if we didn't do this? What if we got people awake and mobile?" And I said, he said that he thought that sounded crazy, even though historically we were doing that in the 70s, by
Yeah.
the way.
Wow.
But these are much sicker patients. These are different diagnoses, new generation. And so he let her try. And they immediately saw a huge contrast in outcomes. Patients got off the ventilator where they were struggling before, they were walking out the door, everything was doing better, but she had a hard time getting the rest of her team to do that as a standard. They were scared, they were hesitant, but Polly just spiritually knew that this was the right thing to do.
Yeah.
So when the hospital started a new ICU, they gave Polly the charge of start hiring the new nurses. Instead of hiring ICU nurses, she hired nursing home nurses who knew nothing about ICU care and said, "I'll teach you everything. Here we keep patients awake and mobile." And they were a blank slate, so they knew nothing else. And so initially they were taking patients from that first ICU, that shock trauma ICU that couldn't get off the ventilator, and they were rehabilitating them. And this is what I would make the whole movie about, because they worked so hard on getting people out of delirium, rebuilding their muscles, getting them strong enough to be off the ventilator and get extubated. It was a lot of work, but they developed this expertise and they were darn good at it. And when the physicians saw how well these patients did under Polly's care, Polly's model, they started to send her patients from the ER. And so now they're early on, she's not having to rehabilitate them. And her thought was, if keeping them laying there sedated does this harm that's so hard to fix, what if we don't do that in the first place? So she let them wake up right away, which I call the Bailey method of letting patients wake up right after intubation. And letting them walk within and move within 12 hours after intubation. A lot of times it's even sooner than that. It's like hours after they get the breathing tube. Anyways, they saw how much easier that was, how much better patients did even then. And that became the standard in the ICU. So that was in the late 90s, early 2000s. They published a study in 2007. That was Polly publishing that study saying, hey, it's safe and feasible. You guys think it's crazy, but it's possible. And she set up this huge domino effect in which all these other studies were done. We developed what's now called the ABCDEF bundle to try to point care towards the Bailey approach, the Bailey method. So that would be, I know it's now almost 30 years ago. That's far enough along to say that's history, right? That's a nursing history.
That is historical.
She's still at the bedside. She's still in the ICU. She's a nurse practitioner, still there. It's probably time for her to retire, but this is her life work. And so part of what inspires me as well is carrying on the legacy of Polly Bailey and making sure that her work is standardized throughout the world, because that's been her vision. But we didn't have social media back then. She's very quiet. She's way too humble. And she wouldn't have like a lamb blasted this. She was also up against a lot of resistance. She lost friends. People scorned her. People were nasty to her. She was basically booed off the stage at conferences back in the early 2000s. She was a young female nurse. Of course, no one wanted to listen to her. Of course, she was crazy. Of course, her patients, quote, weren't sick. But she continued this during COVID. Those were sick patients, all the same as everyone else, and yet her outcomes were entirely different. So I would do a whole movie on Polly Bailey.
Yay! Get ready, Polly. You're a living legend, and we are going to do your biography.
Yes, absolutely.
Oh, that's amazing. That really does sound like a movie that you should do, honestly.
We're talking with screenwriters. Things are in the works. They are.
Thank you. That was fantastic. So, where can people find you? We're coming to the end of our show. Where can people find you? How can they reach out to you if they want to implement this in their hospitals or just follow you on social media?
On any social media, you can look up Dayton ICU Consulting, but that's also my website. So www.daytonicuconsulting.com. There you can email me. You can even book an appointment to chat about your team's needs. There's a lot more information found there. There are all the transcripts to my podcast. So if you go to the clinician podcast and type in delirium, patient testimonials, you can look by topics now that there are so many episodes. But you can even just start from the beginning to have context. But there you can find lots of citations in the research to support everything that I've shared.
And we connected on LinkedIn. So I know, you're on LinkedIn and, other socials, Kali Dayton or Dayton ICU Consultant. Who would you recommend to be a guest on the show?
Polly. If you need on the podcast, have Polly on.
That was a trick question.
I know.
But I like to ask my guests because I think it's kind of word of mouth reference. And if I feel this sort of connection to you and you feel that connection to someone else, there's a likelihood that I will also connect with them and they will resonate with my message. So Ms. Paula Bailey, if you're listening, I'm gonna reach out to you.
She's just an example of nurses as innovators. That are looking at it through a nursing lens, that are asking important questions like why not, what if. I don't know that I would have asked those questions
back then too.
I don't know if I would have been as brave as Polly. By the time I came in, Polly had already established it. There was research. I'm just like carrying the message forward. But Polly was the one with the big guts. To challenge this and to face so much. So I think she defies a lot of the nurse stereotypes, and I would love it if you could interview her.
I would love to.
I'll give you her email.
Yes, I will certainly reach out to her. But you also have great guts, big guts too, because even though you carried on her message, you almost had to kind of re-innovate. You did your own part. You fought through your own hurdles. And I know that you're still fighting some hurdles and some challenges, reaching out to hospitals and getting pushback. But it's only crazy until somebody does it. And so keep fighting the good fight. You're doing this for the benefit of patients, and that is what healthcare is all about. I can't say enough how much I admire you for stepping out of the boat and onto the water, even
Thank
though there
you.
are waves and there's sharks and all kinds of things to be afraid of. But taking that bold step of faith is never easy, but it's worth it. And that's where growth happens. It's in the place of discomfort. So very, very happy to have had you on here. Thank you so much for chatting with me, for expanding my lenses as well, and just allowing me to see a completely different side to nursing. Guys, please follow Kali on all her socials. It's been such a pleasure hanging out with her. I hope you guys will share this episode with your friends and with your networks. Like this and subscribe to our channel, and we'll see you next time. Bye bye.
Thank you.
Thanks for hanging with me till the end. I hope you gained some valuable insight into the world of nursing. If today's episode inspired you, please like, subscribe, and share with someone who needs to hear about the amazing work nurses are doing. Let's keep breaking stereotypes and reshaping the narrative together. I'll see you next time.